another video on hematology myeloid updates. This is for the month of Feb that I'm uploading this video. So basically, we are done with MDS in the last lecture. So today it will be MDS, MPN, myelodysplastic syndrome slash myeloproliferative neoplasms that we'll be discussing. So the criterias that have been emphasized on or refined in the latest WHO myeloid HEM5 classification in the chronic myelomonocytic leukemia, mostly that is the most prominent MDS MPN that we deal with. The subtypes, the diagnostic criteria, as well as the blast subgrouping. These criterias have been refined and few new terminologies have been added. All right. So a better way of listening to this lecture would be that if you have the WHO in front of you in the form of an article, your notes, or just as an image on the mobile, you'd better be able to compare what I'm saying and what it was before. I'll highlight what has been added, but it is always better to open it in your mobile as an image form if you have it, and just keep seeing. When I say don't retain it, don't remember it, it is all right. But when I speak, then you can at least see, okay, initially it was this and now it is this. I don't do it purposefully because this is A from an article, B, I remember it, so I just highlight what has changed. But what this kind of teaching, that if you do it, you will be able to remember it also, because it is always easy to remember when someone is discussing the changes. So if I put a table here of old and a table here of new, you won't retain much. But if you do it yourself, that you open the older table and I tell you the newer things, something you will retain 60% of the older table and also what has changed. This is in whatever teaching experience I have right now. I have always realized that if someone who's listening, the audience, if they actively participate in it, they tend to retain things better rather than just hearing about it and seeing it. All right. So for CMML, the first prerequisite criteria is persistent absolute monocytosis greater than 0.5. Initially it was 1 into 10 to the power 9. Now it is greater than equal to 0.5. Alright. And monocytosis more than 10% in the peripheral blood. So this cutoff was 1, which has been reduced to 0.5 to incorporate cases formerly referred to as oligomonocytic CMMLs. Means those cases where clonality is confirmed, evidence of CMML is there, but monocytosis is not 10%, not 1 into 10 to the power 9. But they're still CMMLs to do that, because even I have seen some CMMLs in my short experience where it's not completely coming to 1 into 10 to the power 9, but the features and then finally the clonality proves that it was CMML. To enhance diagnostic accuracy, when absolute monocytosis is greater than 0.5 but less than 1, detection of one or more clonal cytogenetic or molecular abnormality and documentation of dysplasia in at least one lineage is required. What it means to say is that I have reduced the count from 1 to 0.5. Clear? But this is not enough, because there are reactive conditions where you might get monocytosis of this number or this number or 0.8 also. Fine, I'm just giving random numbers. So especially for monocytosis between this range 0.5 to 1, we also have to prove that this is clonal monocytosis, not polyclonal. Clonality means it's a malignancy, single clonality. And we have to also display, since it's an MDS MPN, there's proliferation and dysbiosis. So you have to also, this was there before also. So you should also have MDS evidence of dysbiosis in at least one lineage. And then some new names have come: CML MDS and CMML MPN type, depending on the counts, which I'll take up later. So this is the table that I am talking about, and I'm asking you to open the older table in front of you so that you can see. Fine. So the diagnostic criteria initially was just the major and the minor. Now they have a prerequisite and a supporting. And then there's another requirements for diagnosis. All right. So what is prerequisite? Persistent absolute monocytosis more than 0.5 and relative, that is 10%, peripheral blood monocytosis. Blast count less than 20% of the cells in the peripheral blood and bone marrow, but there's a rider. Please remember there's an A written over here, which I'll show you अभी. So लेस 20% से कम ब्लास्ट होने चाहिए, 0.5 से ज़्यादा मोनोसाइट्स होने चाहिए. Not meeting criteria for CML or any other MPN, there's a rider over here B. Not meeting criteria for myeloid or lymphoid neoplasm with tyrosine kinase fusion, ये नई एंटिटी है, इसके लिए भी एक राइडर है C. Alright. What are the supporting criteria? As I told you, dysplasia involving more than one myeloid lineages with a rider D. Acquired clonal cytogenetic or molecular abnormality, abnormal partitioning of peripheral blood monocyte subsets, there's a rider E. Alright, so you have to detect dysplasia and clonal or cytogenetic abnormality and abnormal monocyte subset in flow. Fine. This is a flow finding, this is a molecular and cytogenetic finding. What are the requirements for diagnosis? Prerequisite criteria must be present in all, means this thing should be there in every case. Now coming to the supporting. If monocytosis is more than one or more supporting criteria must be there. If it is between 0.5 to 1, supporting criteria 1 and 2 both must be there. So if monocytosis is more than 1 to 10 to the power 9 and you have blast peripheral less than 20%, other MPN criteria have been ruled out, then either you get dysplasia in one lineage or you get clonal evidence, then you can call it CML. However, if monocytosis is between 0.5 and 1, then both these criteria, dysplasia as well as molecular evidence, should be there to call it CMML. Okay. Subtyping, it is myelodysplastic type and myeloproliferative type. In dysplastic type, the counts are low, less than 13 into 10 to the power 9, that is a total WBC count. And in proliferative type, the counts are high, more than 13. It is something where you used to read about hypogranular APML and APML as such, where one used to have leukocytosis, better prognosis, the other used to have lesser counts, normal TLCs, and better prognosis. So subgrouping criteria is based on percentage. This was based on the DLC, TLC now based on blast percentage and promonocytes. CM ये पहले से भी था. There was CML 0, CML 1, CML 2, 0 has been removed. 1 less than 5% in peripheral blood, less than 10% in bone marrow. 2 5 to 19% in peripheral blood and 10 to 19% in bone marrow. Now what was that ABCD? A, blast and blast equivalents include myeloblast, monoblast and promonocytes. So वो less than 20% blast का जो second criteria था उसमें ये भी आते हैं. Promonocytes भी less than 20%. B, myeloproliferative neoplasm can be associated with monocytosis at presentation or during course of the disease and can mimic a CMML. In these instances, a documented history of MPN excludes CML. The presence of MPN features in the bone marrow or high burden of MPN associated mutation, JAK2 CALR MPL tends to support MPN with monocytosis rather than CML. So where they have given the criteria, all the criteria of MPN should be ruled out. So here are those criteria that JAK2 CALR MPL mutation should not be there. Prior evidence of an existing MPN should not be there because there are chances where CML is associated with monocytosis. So when you rule out that there is no prior incidence of CML or JAK2 CALR NPL mutation is not there, then only call it CML, don't call it CML otherwise. Then the criteria, C is criteria for myeloid lymphoid neoplasm with TKI should be specifically included in case of eosinophilia. So if you get a case where you are confused whether it is CML or CML, and then that there's this latest group of myeloid lymphoid neoplasm with tyrosine kinase fusion, you have to rule out कि eosinophils तो नहीं दिख रहे बढ़े हुए इसमें, and अगर ऐसे पिक्चर में eosinophilia भी मिल रही है, you might want to rule out myeloid lymphoid neoplasms with TKI, tyrosine kinase fusions, rather than calling it a MPN or an MDS MPN. D is morphological dysplasia should be therein. That is in the supporting criteria. There's a prerequisite and then there's supporting. So in supporting I told you कि 10% से ज़्यादा एक lineage में dysplasia मिलनी चाहिए, उसमें एक rider था. Morphologic dysplasia should be present in greater than 10% of cells of a hematopoietic lineage in bone marrow. Last E, based on detection of increased classical monocytes in the absence of known active autoimmune disease or systemic inflammatory syndrome. What it means to say is कि when clonality risk detect करते हो तो ये autoimmune conditions and सिस्टमिक इन्फ्लेमेटरी सिंड्रोम्स में बढ़ सकता है मोनोसाइट्स, इसीलिए क्लोनालिटी इज इंपॉर्टेंट टू बी डिटेक्टेड. So the types are CML, MDS-MPN with neutrophilia, MDS-MPN with SF3B1 mutation and thrombocytosis, MDS-MPN NOS. Last, the term MDS-MPN with neutrophilia replaces atypical CML. See, CML MPN से चला गया वो MDS-MPN में. MDS-MPN with ring sideroblasts and thrombocytosis is redefined based on SF3B1 mutation. Alright, and renamed MDS-MPN with SF3B1 with thrombocytosis. रिंग सिड्रोब्लास्ट का मतलब ये नहीं है कि MDS हो गया, इसमें थ्रोम्बोसाइटोसिस भी है, तो इसको इस ग्रुप में डाल दिया गया MDS-MPN में. The term MDS-MPN with ring sideroblasts and thrombocytosis has been retained as an acceptable term to be used for cases with wild type SF3B1 mutation with greater than 15% ring sideroblasts. Why? बिकॉज 15% से रिंग सिड्रोब्लास्ट ज्यादा दिख रहे हैं और इसमें भी डिस्पोसिस होती है, तो हम इसे एमडीएस में डाल सकते थे, राइट. एमडीएस में भी म्यूटेशन लेटेस्ट इंट्रोड्यूस है, आपने लास्ट टाइम देखा है. बट ऐसे केस में जहां आपको 15% से ज्यादा यू आर गेटिंग रिंग सिड्रोब्लास्ट but you are also getting an SF3B1 mutation, you can still put it in MDS-MPN, no problems. All right. MDS-MPN unclassifiable is now termed as MDS-MPN NOS, not otherwise specified. This is in line with intentional efforts to remove that, something is unclassifiable, then you can't classify it as MDS-MPN. So just like in breast, it is IDC-NST, no specific type. Similarly, they have introduced a parallel in hematology over here, MDS-MPN, no, not otherwise specified. But it is yet an MDS-MPN rather than calling it unclassifiable. Alright, it's a paradox actually. You classify something as MDS-MPN and then say it's unclassifiable. That doesn't sound correct. So that's it for today. A short 10-12 minute tutorial. Next, whatever the paper tells, it's AML I suppose. Next I'll be taking AML whenever I upload, hopefully by the end of this month. And so I hope you like this, and I'll come back next month with the other part of the myeloid updates. Thank you.